Many people take medicines for cough and cold. Are you aware of what's available and what is suitable for you? I'm William Lim. Join me in this video lecture on drugs in cough and cold. Let's go. Over here, cough is the most common reason for visiting a primary care clinic. This is also the same for the US and Australia, where cough is the most common complaint, leading patients to consult their primary care physicians. That's because the common cold is very common and is almost always accompanied by a self-limited acute cough. Now, we are all familiar that after seeing a doctor, we are given an assortment of drugs for cough and cold. And in fact, this is a very huge industry. In 2017, US consumers spent $8.6 billion on over-the-counter cough and cold products. Now, in this editorial, Dr. Dickinson says that this kind of drugs may be helpful, but few doctors know the science of prescribing them. And sometimes it is done badly, partly because it is difficult to ascertain the science behind all these trivial disorders, and that few medical schools or training programs actually teach about them. So it's important for us to consider these principles. So cough itself is a defense mechanism for clearing the airways of potentially harmful particles, chemicals, secretions that might otherwise compromise ventilation. And sustained coughing leads to a lot of potential problems that we are aware of, like loss of voice, being self-conscious, vomiting, headache, insomnia, urinary incontinence, and other things. Now, there are many cough receptors in the airways and lungs that are sensitive to stretch or pressure or chemicals, and the impulses from these stimulated cough receptors travels an efferent pathway through the vagus and non-vagal sensory pathways to a cough center that's located in the medulla, and some cough suppressants actually act on this center. The cough center then generates an efferent signal that travels down the vagus, phrenic, and spinal motor nerves to the expiratory muscles to produce the cough. A cough may be subacute, acute, or chronic, depending on how long it lasts. And the duration of the cough at the time of presentation helps to determine the likely causes. Acute coughs last less than 3 weeks, and subacute coughs goes from 3 to 8 weeks, while chronic coughs last more than 8 weeks. Acute coughs are usually caused by the common cold or influenza, or allergens or infections such as pneumonia. But people with influenza are sicker than those with common colds. In the influenza, there's a dry cough usually, while in the common cold, the cough is usually productive, meaning that there is usually a phlegm being coughed up. Subacute cough may be due to asthma or sinusitis or post-infectious cough, where after upper respiratory tract infection, there may be inflammation of the airways, and this causes cough because of mucus production or the increased sensitivity of cough receptors. Post-nasal drip refers to the nasal secretions which continue to drip down the pharynx or the larynx and which stimulate the cough receptors. Chronic cough can be present in about 10 to 12% of the population. There are many causes of chronic cough. One of them is upper airway cough syndrome, and this is the cough that happens after rhinitis, sinusitis, or post-infection, and is due to post-nasal drip or sensitized or inflamed upper airway cough receptors. There are many other causes of chronic cough, such as gastroesophageal reflux disease, asthma, TB, lung cancer, and so on. Chronic cough can also be drug-induced, such as the side effect of ACE inhibitors, where about 3 to 30% of users of ACE inhibitors may experience a dry cough after starting. The cough from the ACE inhibitors may start hours after starting the drug or after months. And upon stopping the drug, the cough may take 1 week to 3 months to go away. One possible mechanism for ACE inhibitor-induced cough is that ACE inhibitors reduce the degradation of bradykinin, leading to the local accumulation in the lungs. It may also activate pro-inflammatory peptides such as substance P. All of these can then activate cough receptors, while prostaglandin can also increase the sensitivity of cough receptors. If cough occurs, the ACE inhibitors can be replaced with angiotensin receptor blockers, which does not affect the cough reflex. Or else the patient, once the cough has stopped, can also be re-challenged with ACE inhibitors, and this time the cough may not return. Cough can be treated either specifically, that is to treat the underlying cause, or else it can be treated non-specifically, where we only suppress the cough. We do this when we don't know the underlying cause, or if the specific therapy will take time to work, or if there is no effective therapy, such as in terminal cancer. There are two groups of cough suppressant drugs: protussive drugs, which increases the volume of respiratory secretions to increase the effectiveness of cough in order to remove excessive mucus, or antitussive drugs, which is meant to stop the cough by reducing the sensitivity of the cough reflex. We use protussive drugs in wet or productive cough, that is, the cough is performing a useful function to clear the airways of the mucus, and so the treatment is to make the cough more effective by thinning the secretions. Whereas antitussive drugs are used to stop the cough when the cough is non-productive, it is dry, and so it does not produce any useful function. The cough is only dry, irritating, and tickling, and so the antitussive drugs then is meant to stop the cough. Cough is the most common reason people seek medical help. Many people come to the pharmacy to seek over-the-counter remedies for symptom relief. Let's take a look at the options available. We will now look at the four types of cough suppressant drugs. First, drugs for mucus hypersecretion. There is a layer of mucus lining the surface of respiratory tract that traps dust, microbes, dead cells, etc. And the motion of the cilia helps to move mucus up to the back of the throat to be swallowed or spat out. We will now look at the two types of mucoactive drugs, that is, the expectorants and the mucolitics. First, we'll look at the expectorants. The purpose of the expectorants is to increase bronchial secretions to reduce the viscosity of the mucus layer so that it can be removed more easily. One of the most common cough syrup is the Expectorant Guaifenesin. Let's look at the different preparations available. It has been postulated that guaifenesin exerts its expectorant activity by irritating gastric mucosa, and that increases the respiratory tract fluid secretions. However, it seems that there is lack of clinical evidence for benefit of expectorant in actual clinical use. So then why do we use this medication? It could be because, as this review article says, that a component of the effect could be via a placebo effect. That is, that we actually feel better because we think that we have taken something useful, or perhaps that the sweet taste causes release of endogenous opioids that makes us feel positive. A second expectorant that's in the hospital list is ammonium and ipecacuanha. And ammonium citrate is actually helps to irritate the bronchial mucosa, causing the production of respiratory tract fluid. Whereas ipecacuanha is an emetic agent, but at the lower dose, it is an expectorant. But it is no longer used as an emetic because of side effects, including CNS depression. You can see the warning here that for ipecacuanha that you cannot take more than 4 doses in 24 hours. The next group of drugs is mucolitics, and the example is bromhexin. So basically, it disrupts the structure of fibers in sputum to produce a less viscous mucus, which is easier to expectorate. Now we move to the second type of cough suppression drugs, which is the first generation H1 antihistamine drugs. So the two examples are diphenhydramine and chlorpheniramine. So basically they block the histamine H1 receptors, and histamine is responsible for airway inflammation, but at the same time it also blocks muscarinic cholinergic receptors, giving the anticholinergic effect. And this group of drugs actually crosses the blood-brain barrier so that it can block those receptors in the central nervous system. This is in contrast with the newer second generation antihistamines, which does not cross the blood-brain barrier and has no anticholinergic effect. And so the second generation antihistamines are not very useful for cough and cold, but more for allergy. The mechanism of first generation antihistamines for cough and cold is first of all a central antitussive action, so the cough reflex is suppressed centrally, and second of all there's a drying effect of nasal secretions and post-nasal drip, and this is by way of the anticholinergic effect. Histamine H1 receptors help to maintain the waking state in the daytime, and so therefore blocking of H1 receptors can cause drowsiness and daytime sleepiness, and this may have adverse effects on those who need to go to school or work or need to drive or operate machinery. So this is a caution for them, and as well as caution in the elderly, and also to avoid alcohol. The other important side effects are the anticholinergic side effects by blocking of the cholinergic muscarinic receptors, and the effects should be well known, such as dry mouth, blurred vision, and all that. The third group of cough suppressant drugs is dextromethorphan, and dextromethorphan is structurally similar to opiates, but it does not bind the mu receptors. The exact mechanism is still not clear. It is fairly well tolerated, and it suppresses cough by a central effect. And but however, there is no evidence of clinical significance in terms of its antitussive effect. However, it is useful because it's generally non-sedating. Side effects are dependent on dose. For those who take too high a dose, they may get euphoria, hallucinations, and a dissociative state. And so those who have habitually take high doses may start to, because of the euphoric effect, they may have some craving and become habitual users. And so these people may get those adverse effects associated with high dose. And this is an illustration of people who are abusing dextromethorphan by taking high doses. And then the last group of anti-cough suppressant drugs is demulcents. And demulcents basically help to increase saliva production and flow. So things like lozenges and honey act as demulcents. They also form a protective covering over irritated pharyngeal mucosa, and also form a covering over sensitized cough receptors. So both these effects can reduce the tendency to cough. Now we move on to drugs for cold. The symptoms of fever and sore throat and cough could be due to various things. It could be due to influenza, which needs an antiviral drug, or it could be due to a bacterial infection, which needs an antibiotic. But if it's due to the common cold, then the only treatment is symptomatic and supportive. And for the common cold, 50% of patients have a sore throat, 40% actually present with cough. The symptoms basically clear by 1 week. The first group of drugs for cold is, as you've already mentioned, the first generation H1 antihistamines, and so they are able to have a central effect against coughing, and they also dry the secretions, which benefit from the nasal secretion, runny nose, as well as tearing. The second group of drugs for cold is decongestants. And decongestants, the the inflammatory mediators causes vasodilation of blood vessels at the nasal passages, and this vasodilation thus reduces the airway patency. And so nasal decongestants are alpha-1 adrenergic agonists, which works to constrict the blood vessels, and then this helps to restore the airway patency and clear the nasal stuffiness. An example of an oral decongestant is pseudoephedrine, and in terms of the side effects, it basically causes there may be excess activation of the sympathetic nervous system, and so this will require caution in patients with a history of hypertension, who have thyroid problems, or with heart disease. It is also available as a nasal drop or nasal spray. An example of that is oxymetazoline. For this topical decongestant, it cannot be used for more than 3 to 5 days continuously, because if it's used continuously, there might be a worsening of the symptoms, and this is because of the inability to vasoconstrict that occurs after continued use more than 3 to 5 days in a row. In terms of drugs that's effective for the common cold, there are two. First one is the first generation antihistamines, which may help in the rhinorrhea, the runny nose, and the second one is the decongestants, which can provide short-term relief for the nasal congestion. We've already encountered upper airway cough syndrome, which we said that was cough resulting from postnasal drip or by inflammation of the upper airways. And so the treatment for upper airway cough syndrome is actually a combination of first generation antihistamine together with decongestant. So this will centrally suppress the cough reflex. It will dry the nasal secretions and also help to relieve the nasal congestion. And if the resolution of these symptoms will help to confirm the diagnosis of upper airway cough syndrome. The next group of drugs for drugs in cold, we're going to consider topical sore throat treatment. And this picture shows that there are various different kind of gargles, throat spray, and lozenges that's available out there. What you saw just now was benzidamine, which provides some topical analgesia for sore throat and is available as a gargle and also available as a spray or lozenges. The next one is a mouthwash, which is from coaxium gluconate, and this actually has activity against bacteria, fungi, and even some viruses. And another treatment is lignocaine, viscous solution. This is a local anesthetic, which is useful for sore throat as well. Next, we're going to consider the topic of multi-ingredient cough and cold mixtures. And there's many of these products in the market. And this is an example of one, Cough Linctus Plus. And you can see from the list of ingredients, some of the drugs that we've already mentioned earlier on. So you can look at the drugs and recall their functions and try to work out what this preparation is for, what symptoms is it treating, and whether it is a rational combination. So we need to evaluate that. In terms of advantage of taking a multi-ingredient cough and cold mixture, number one, with just a single dose, you get to take multiple drugs, so you don't need to dose multiple times. But there are obvious disadvantages as well. First one is that if one of the symptoms changes or is not present anymore, you cannot exclude one of the drugs because all the drugs are in the same mixture. And also sometimes different preparations, a patient may be taking several things from different sources, and they may actually have the same overlapping ingredient. So if you're not taking single ingredients, you might actually take a double dose of one or two components. Lastly, we're going to treat the topic of treatment of cold in children. So for the treatment of pains and fever, we can use paracetamol as well as ibuprofen. Paracetamol is available as drops for kids up to 2 years, and as a mixture for 1 to 6 years, and also mixture for more than 6 years, or as well as chewable tablets for 6 to 12 years, and also as a suppository form, which is useful for all ages. Ibuprofen is only to be used for children more than 6 months old, and preferably not on an empty stomach. And aspirin is not recommended for anyone below 18 years old because of the risk of developing Ray's syndrome. In terms of treatment of sore throat, it's only recommended to use safe and soothing remedies, such as in drinking and drugs for analgesia. Now, the FDA does disallow the use of over-the-counter cough and cold products for children below 2 years of age. This refers to the antihistamines, decongestant kind of products, which is not to be given for children below 2 years of age because of the danger of side effects. In terms of dealing with nasal stuffiness, the advice is not to use those decongestants, but to use either saline nose drops or nasal suctioning. So for saline nose drops, basically the saline drops can be dropped into the nasal passages, and this will help to soften the dry or the thick nasal mucus, and helps to keep the nasal passages moist. So this may be sufficient to clear the nasal stuffiness of the little child. The other option is, after doing the saline nasal drops, then it's possible to use suction to remove the mucus. You can use a bulb-shaped piece which is connected to a suction machine, and the piece is then placed outside the nostril, and then the sucking starts. And or else it can be like a bulb suction, and the tip is put into the nostril, and then use the bulb to provide the suctioning to remove the mucus out of the nose.
There goes my friends leaving. My coffee's the reason I'm losing my voice. What can I take? Attack Guaifenesin. If phlegm is the reason for expectorant, but this I'll take. My Dextrometal Fan goes right up to my brain. I won't feel sleepy, it's just got suppression. But now I crave for more, and cough's not the reason.